Sir, we are live now. With all your permission, I'm starting this
Yes.
session. Good evening, everyone present here. I am Faraz from IJCP. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, none other than Dr. Quresh B. Muscati, sir. Sir has done MBBS, MS, TOMS, FCPS, FICS, and consultant ophthalmologist at Muscati Eye Clinic, Mumbai. Today he is going to discuss on a topic age-related macular degeneration, that is AMD. Let me share some of the overview of the topic. Age-related macular degeneration, that is AMD, is a progressive eye condition that primarily affects the central part of the retina called macula. The macula is responsible for central vision, which is essential for activities like reading, driving, and recognizing faces. AMD is the leading cause of vision loss in people over the age of 50, affecting millions of individuals worldwide. To more know about this topic, I would like to invite sir and hand over the session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Faraz. And I will just share my screen. Thank you for inviting me to this. And this is a very important subject. Yeah. This was formerly called SMD, or senile macular degeneration, till senior citizens got upset at the use of the word senile. They said we are not senile, which was a derogatory term. So it was changed to age-related retinal degeneration, or ARMD, age-related macular degeneration, not retinal, sorry. And then it was further modified to just age-related macular degeneration. The R was dropped. So it became AMD. More information is in my book, Simplifying Eye Care, which is available with me for anybody who wants it. Let us first do some basics of what is the retina and how do we see. So just to refresh the memory of everybody, we have the clear glass in front of our watch, which is called the cornea, through which light passes. It hits the lens of the eye, just like the camera lens in the old days, in the film cameras, which you can see. And then it is focused on the back of the eye where there is a film, like the old film cameras. Now we have digital cameras. Youngsters will not know, but those above 40 will know that we have something called film cameras. So that inner yellow lining that you can see, that's called the retina. So the light focuses on the retina. There it is converted from light energy into chemical energy and then into electrical energy. And there are 2 million cells on the retina. Each of them is connected like a TV cable through a nerve, a small little nerve, which goes through the major channel called the optic nerve to the brain. And so it's converted to electrical energy, and that's how you see through the brain. Now, the most important part of the retina, you can see that whole yellow area. There's a small dimple there that you can see called the macula. 80% of our vision takes place through that small tiny area called the macula. All our color vision is over there, and all our near vision is at that macula. So it's a very important small dot in the retina. And if something goes wrong there, then we get what is called age-related macular degeneration. So let me briefly go through some of the common questions that people will ask family physicians. Oh, occasionally get pain at the back of my eyes. Is it a retinal problem? Remember, retina has no nerve endings, no nerve fibers, no pain fibers. So if there's any pain at the back of the eye, it is not a retinal problem. It could be sinuses, it could be headaches, it could be anything else. I occasionally see some flashes and floaters. Is that dangerous? No, unless there are persistent flashes of light and the floaters increase exponentially. You see 5 floaters just now. 2 minutes later, you see 100, and 5 minutes later, you see 1,000. That is dangerous, where you need to go and show it to a doctor, a retina specialist or an eye specialist, because you could be having a retinal tear or an impending retinal detachment. The retina detaches itself from the back of the eye. In which case, can I wait a couple of weeks for treatment? No, you cannot. It's an emergency. If there is a tear that you can see in the upper corner, tear before the laser, there's a small red area, that's the hole which is there. We apply laser around it and seal that tear. Or we can apply a freezing ice ball called cryopexy from the outside to seal the tear. Sometimes you're too late and the water has flown under that hole through that retinal tear and lifted the retina, causing a retinal detachment. If a lot of fluid has gone in, then you get what is called a balloon retinal detachment, where it balloons up that gray zone that you can see. Then we have to do retinal detachment surgery, which can be either a vitrectomy, where we eat up the inside just in front of the retina, the vitreous, or we do it from outside, where we put a buckle, just like you put a belt and buckle for a person to wear his trousers. So some more common questions. I'm short-sighted with high number glasses. Can I play sword, swim, and lift heavy weights? Yes, please go ahead. It doesn't cause detachment. Coming to the subject of the day, my grandmother finds it difficult to read small print. That is usually due to macular degeneration if it is not due to cataract. So the eye surgeon will look into the inside of the eye. He will either see a cataract, in which case he will advise cataract surgery, or you will see macular degeneration. So the macula is that central area. You get two types of macular degeneration. It could be dry or it could be wet. On the nerve of the eye is seen with those blood vessels coming out. Just to the temporal side of the nerve is where the macula is situated. And if it's dry AMD, then you get cholesterol deposits, small little deposits of yellowish cheesy material made of cholesterol and like-minded things. And that's called a dry AMD because there's no fluid. There's only those spots, yellow spots, as you can see in the first picture. In the second picture, where it's wet AMD, you may or may not get these cholesterol deposits, but you get fluid or you get blood from leaky blood vessels. So some new blood vessels are formed under the macula and they are leak. When they leak fluid and they leak blood. So you can see little reddish pigment over there. So that's blood over there. And again, the picture on the other picture, you can see dry AMD where you can just see some yellowish area. And in the wet AMD, you can see that dark blood clots which are there in the center, which is in the macula. The black and white pictures are a test called OCT or ocular coherence tomography, which is what is chiefly used by us eye surgeons to diagnose whether it's dry or it's wet. I will talk about it in future slides. So to summarize, macular degeneration causes loss in the center of the field of vision because the macula is in the center of the retina. In dry macular degeneration, the center of the retina deteriorates gradually over time. It's a very slow process. Gradually, the patient feels his vision is going down. They come to us late because they feel it's because of age, cataract, and things like that. And even if they come early, there's nothing much that we can offer them. We'll talk about treatment later. In wet macular degeneration, as I told you, there is leaky blood vessels growing under the macula. And when those leaky blood vessels leak, then you get a sudden drop in the vision. So a wet AMD can be slow if there's very little leakage of fluid over time. But most often there is a sudden drop in the vision, especially central vision. So these are some pictures of dry ARMD or dry AMD. Early you see just 2 or 3 yellow spots. That nerve that you can see, the whitish yellow with the blood vessels coming up, that's the optic nerve. The temporal side of it is the macula, which is a little dark area. You can see a few yellow spots in the early pictures. Moderate amount of those cholesterol deposits all around the macula. But the central area called the fovea, center of the macula is the fovea, is spared just now. So his vision may still be good in spite of moderate dry ARMD. And in the third picture, you can see where it's severe, where the yellow spots are even in the center, which is the fovea. So definitely this patient will be very symptomatic. I told you about the pictures that we take, like the CT scan in the brain. We have OCT or ocular CT, ocular coherence tomography. So you get these wonderful, you can get it in black and white or you can get it in color. You see the first picture where I've written drusen under macula. Drusen are the cholesterol deposits. The macula, you can see the retina of the thick area that you can see, that's the retina, and it dips down and comes like a valley. So if that valley contour is preserved, then it is a dry macular degeneration. In dry, until a late stage, that valley, the dipping that you can see is preserved. And in the lower area, you can see the drusen under the macula, those bumps that you can see, that's the cholesterol deposits. In the next picture, you can see where I've written macular contour normal. So that's the dip or that valley, which is well seen. And those large drusen, that whitish things like small mountains that are pointed to. So those are the drusen or the cholesterol deposits there. Sometimes those drusen join together and form a geographic area, just like a small island or something, as you can see in the lower picture where I've written geographic atrophy. So the drusens all merge. In the color picture, you can't see individual mountains. You can see it's a yellowish area where all the drusen have merged together. So you can have color images showing the drusen. Drusen is nothing but cholesterol deposits, or you can get a geographic atrophy. See, these are variations of dry AMD, the OCT images. So next time a patient comes to you as a family physician and shows you these pictures, you can pretend to be very knowledgeable and tell him, oh yes, this is dry AMD. Don't worry about it. Wet AMD is a different kettle of fish altogether. You see the optic nerve, which is there. That's the first picture, is a diagrammatic version. The blue and the red. The blue are the veins and the red are the arteries. And next to it in the temporal area should have been the macula, but there's a large red hemorrhage that you can see, or a blood clot there. And that was a stylized artist picture. But the middle picture where I've written wet AMD, you can see that just between the disc and the fovea, that there's a red, like a comma shape, inverted comma shape red area. So that's the blood clots there, and the cloudy appearance next to that, that's some fluid which is deposited. So you can get blood or fluid under the macula from leaking blood vessels. The third picture that you can see is the blood clots which have remained for some time and become quite blackish and lifted the retina because such a big blood clot. While the lower picture that you can see is a small blood clot just under the fovea or just under the macula area. So it can take all shapes and sizes. Whenever we see a patient with either dry or wet AMD, we want to make sure that it's not wet. So we will always ask for an OCT test, which will exactly pinpoint how much fluid is there, what is the thickness of the macula. It measures it in microns and tells us. We know that the normal thickness should be about 200 microns. If it is 300 microns or more, we know there is fluid underneath. So these are some of the images, OCT images of the wet ARMD. You see the black spaces are the fluid or the blood. So in the initial, you see the number D that I've written. The macular contour is still preserved. You can see the dip there, but you see that black area underneath, which is a fluid with blood, fluid or blood over there. And soon the retina gets lifted up and the dip is no longer there. You can see in the lower picture where I've written black spaces of fluid, blood. You see that the retina is now raised like a mountain. And in the color picture next to it, also you can see there are some black areas, which is the fluid and the blood, which is under the retina, which is lifted up. So the macula you can see is lifted up like a small mountain over there. That's the color picture that you can see. So retina gets lifted up initially in the initial phases in wet AMD. You might still get the macular contour, but then soon it gets lifted up like a mountain shape. So what are the symptoms of ARMD or AMD? They will start with difficulty for near work, including for reading. So they find difficulty in seeing small print, then they find difficulty in seeing even big print. Then they might find distorted vision, especially for near. They say that the words appear all distorted. Some of the words appear bunched up next to each other. Some of them appear far away from each other. So distortions are there. You can get a dark patch in the center of the visual field. You see that girl picture, a patient with AMD, whether it is dry or wet, you see a dark patch where the face should be, and you can see the background well. So the central area becomes like a dark patch, and he's very disturbed, especially when he's reading or he's checking his mobile phone, because the central area is the most important area. He can't see. If he's reading a book, he can see the words at the beginning of the sentence and end of the sentence. But in the middle of the sentence, there's a gray zone or a dark zone. You may see a few floaters, and gradually the vision keeps going downhill. So these are some of the symptoms that alert us that this is an AMD. So what are the diagnostic tests that we do? I told you about two of them. One is we look inside the eye with an ophthalmoscope. The retina is one of the few tissues that you can see with the naked eye. So with the ophthalmoscope, we have two types called the direct ophthalmoscope, in which we look directly inside, or an indirect ophthalmoscope. We wear it around our head and have a 20 diopter lens through which we look. And we have now fundus cameras. Fundus is the retina. So we can take serial photographs of the patient's eye and follow it up over time to see whether it's worsening. So you can take fundus photographs. We do what is called fluorescein angiography. When we want to pinpoint the leaky vessels, we feel there are one or two just leaky vessels and we may want to laser them. Then we do a fluorescein angiography, very much like a coronary angiography. We inject a fluorescein dye through the vein in the forearm, and in about 10 seconds, the fluorescein dye appears in the retina. And if you're taking color pictures, then you can see it as green. But if you see black and white, you can see these are the black and white images in the lower part of the macula, and there are certain areas which are non-perfusing. That means there are dark areas in the fluorescein angiography. So those areas the fluorescein dye is not being able to see. We can't see it because it's being covered by blood or by fluid. And then the newest technique which has come in the last 5 years, without injecting any dye, fluorescein is after all a dye. You can get a reaction to the dye, idiosyncratic allergic reactions. We have something called OCT angiography. That means the OCT that I showed you earlier, a little tweak in the machine, a little more expensive machine, can pinpoint the blood vessels, and you can go layer by layer in the blood vessels and see exactly which blood vessels are leaking, how deep they are, how many they are. So that's called OCT-A, we call it for short, or OCT angiography. So three major investigations: fundus photography, OCT, and OCT angiography. Fluorescein angiography is now seldom done once OCT angiography is coming. Let us move on to the treatment for ARMD. Do we have anything specific? Well, for dry ARMD, we don't have much. When we don't have much, then we say we need what is called antioxidants. Antioxidants are the things which keep the macula healthy. So diet which is rich in antioxidants, also called carotenoids, such as lutein, zeaxanthin, astaxanthin, vitamin C, vitamin E, these are all supposed to be good. So what sort of diet should we advise? Fresh fruits. In the fruits, the kiwis, the oranges, the grapes, and yellow squash, these are the best fruits containing the rich amount of carotenoids. And fresh vegetables. Amongst the vegetables are spinach, zucchini, collard greens, green leafy vegetables. These are good for preserving the vision to the extent possible. And of course, when we have this in the diet, people want pills containing this, so the pharmaceutical industry must survive. So they make antioxidant pills with containing lutein, zeaxanthin, astaxanthin, vitamin C, vitamin E, ginkgoa biloba, bilberry extracts. These are some of the pills that are given. We don't really know if they work, but the pharma industry must survive. So we do prescribe them because there is some evidence in large population-based studies that diets rich in antioxidants do slow down the progress of AMD. So for dry AMD, the treatment options are very limited. In early stages, we can change the near glasses to those of higher power. If that doesn't help, then we give them what is called low vision aids, magnifying glasses in the hand, magnifying glasses in their spectacles, telescopic glasses, so that they can see it bigger. If the vision drops down further, then we have computer software such as JAWS, in which the computer reads the material which is there and converts it into audio. So the person can read a book with the words being converted into audio by computers apps such as JAWS. With that, people are able to read books every day. So they can hear a book instead of reading a book. And now the latest thing that we have, maybe some of you have seen the WhatsApp, which has gone viral, of Lionel Messi and smart glasses. Well, I'm proud to say that we have smart vision glasses in India, made in India, at 1/10 the price of those which are abroad. We get them for around 50,000 rupees. They're available at my clinic. So they have a small miniature camera at in one of the handles of the spectacle, which takes pictures, and then it converts that picture into audio. So it tells the patient that there is someone approaching you. He's about 40 years age with a mustache and wearing a dark pair of glasses. All that they can tell you. And then if you tell the app that this is my father, then the next time the thing will say your father is approaching you. So it tells you about people approaching. It can read any text, handwritten text, as well as what is written on a computer screen or is written in a book. It can even read my handwriting, doctor's handwriting, which is fantastic. And if you go out with these glasses on, and if you focus on the road, it can tell you that there is a pothole coming up within a meter from you. Or if you look straight, then it can tell you there is a lamp post 1 meter away. So depending on which direction you turn your face, it can give you guidelines so you don't bump into objects. So these are also available. As far as wet ARMD is concerned, we have what is called anti-VEGF injections. Let me explain to you. What happens is that, why do we get wet ARMD? Because I told you there is leakage of fluid and blood from new vessels which are under the retina, under the macula. Now, why do you get these new vessels which are so leaky? It's promoted by a substance called vascular endothelial growth factor. Vascular means to do with blood vessels. Endothelium is the inner lining growth factor. So it promotes the production of poor quality new vessels. VEGF, VEGF, or vascular endothelial growth factor, is something which is produced in the macula of those with macular degeneration. An excessive quantity of this is produced, so it makes new vessels which are leaky. So if you give a material which is anti-VEGF, then that promotion of growth of new vessels will not be there. So therefore, the industry found that let us inject anti-VEGF. Where do we inject it? We can't inject it into the macula because macula is a very sensitive area. You'll destroy the cells there. So we inject it into the jelly which is in front of the macula, which is called the vitreous. So you can see the picture there, that just about 3.5 millimeters away from the limbus or from where the cornea ends, we inject with a very thin needle, 27 gauge needle, a small amount, 0.1 ml of an anti-VEGF. It's a liquid which goes through the vitreous, it goes to the retina and helps the newly formed vessels to close down and prevents new ones from sprouting. So the vessels which are already formed, it helps it to close down and prevents the new ones from coming up. So this should be a fantastic thing, right? It is and it is not, in the sense that it doesn't help everybody. It helps a few people and it may not help everyone. And we don't know in whom it will help and in whom it will not help. But it's the only thing that we have available as of now for wet ARMD. So these are called anti-VEGF injections. So the questions that you will ask me is, do they work? The answer is yes and no. As I said, in about 60–70% of cases, they do stop the blood vessels from growing. But sometimes the damage is done. If the blood has leaked out and has been there for some time, it forms a scar tissue. These injections do nothing to the scar tissue. How often do we have to give them? There is a dosage regime. We normally give 1 injection a month for up to 3 months. Sometimes we have to repeat them. Then we do OCT again to see whether the thickness of the fovea or the macula is going down. We may need to repeat. If it has become normal, then we don't repeat and we watch. Some of the injections are short acting, so we have to repeat them every month. Some of the injections, which are of course a little more expensive, are long acting and you may have to repeat every 3 to 4 months. But we normally do it after looking at the retina carefully with a fundus camera and doing serial OCT tests as well. Is one superior to the other? You know, actually I have no financial interest in any of these, but one injection called Avastin was discovered by accident. It was being used for colon cancer patients. So it's an anti-cancer drug. But when they gave it to patients, elderly patients with colon cancer, they found that the macular degeneration, wet macular degeneration subsided. So now it is used and it is relatively cheap. And they did a large study and they found that Avastin is not inferior to some of the more expensive injections. There are some pros and cons, and this is not the place to discuss pros and cons of one versus the other. But if a patient is there of macular degeneration, the eye doctor will discuss the pros and cons of one over the other. So really, there is not too much to choose between them, except that some of them need to be given less often than the others. What about retinal transplants? Can we do that for macular degeneration? And the answer is no. There is no retinal transplant yet which has been proven successful, because I told you the retina is connected with 2 million fibers to the optic nerve. So if I change the retina and put a new retina there, how am I going to make those 2 million connections? So there is no retinal transplant. People have been trying to put artificial chips in the retina so that they capture the light, and then the artificial chip is connected by a single wire to the brain, which sees. So artificial chips have been in use. That is what we call artificial retina. But they only tell you for difference between light and dark and little bit of whether a door is open or closed. They've not really given fine vision so far. More comfortable we are with what is called low vision aids that I told you about, the JAWS software and the smart vision glasses that I mentioned that we can do. So there is no such thing as retinal transplant. Patients will keep on asking you these, and the answer is unfortunately is no. With this, I just summarize that there are two types of macular degenerations, the dry type and the wet type. In the dry type, we give them artificial, some antioxidant pills or antioxidant rich diet, and we give them low vision aids. There is no specific treatment. In the wet type, if there is fluid under the macula, then we give anti-VEGF injections, of which there are various types, and they may or may not work. If the macula gets finally scarred with the scar tissue, then there is no other treatment except low vision aids and those smart vision glasses. Thank you so much for your attention. I'll be happy to answer any questions.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors who have joined this session. Sir, I can see we have received some question from the participant. If you allow, can I take this question with all your permission?
Yes.
Yeah, first question I can send from Dr. Agarwal. He's asking which antivascular endothelial growth factor, that is VEGF, agents are used in the treatment of exudative wet age-related macular degeneration.
That's what I mentioned. And the exudative, these are just big words for what is called wet AMD. So there are different, as I mentioned, that the time doesn't permit us to go into all. There are different. I told you about Avastin is one of them. And then there are others called with trade names called Lucentis, Eccentrix, Eylea, and there are many others. All of them, the generic names are very unpronounceable. Ranibizumab, Pegatumab, and things like that. So there are different ones, and the eye doctor is the best to decide which one is to be given. Thank you.
Okay, thank you so much, sir, for explaining this answer. I hope that Dr. Agarwal has received his answer. Moving forward, I can see there are a few more questions, sir. I will be taking another question from Dr. Supriya. She's asking, how is age-related muscular degeneration severity classified by the age-related eye disease study group, AREDS?
Yes, so the AREDS or ARED study found out that the antioxidants are useful for this. That is the finding of the ARED study, and ARED doesn't classify this; it just classifies it into wet and dry. As I said, for the dry, we give antioxidant pills, and for the wet, I told you about the VEGF injections, anti-VEGF injections. Thank you.
Okay, thank you so much, sir, again for answering this question, sir. I can see, sir, there are a couple of more questions. We will be taking last two questions for today's session, sir. Another question from Dr. Subramaniam, and he is asking, what is the role of retinal pigmentation epithelium, that is RPE cells, in the development of age-related muscular degeneration?
The retina as a whole is composed of 10 layers, and the innermost layer is the RPE layer or retinal pigment epithelial layer. During this time of when there is age-related macular degeneration, the RPE layer or retinal pigment epithelium develops cracks, develops breaks in that, and that is what allows the fluid to come under the retina, or which allows the cholesterol deposits in dry ARMD to come there. So it has a big role. But if it is there and it is protecting, then the ARMD will not be so bad. Thank you.
Thank you so much, sir, for answering it. I hope that Dr. Subramaniam has received his answer. I can see last question for today's session from Dr. Anjali Avasthani. She is asking, is papatinib sodium, that is mucogen, used in the treatment of exudative wet age-related macular degeneration? Is it?
Yes. Macugen is now more or less given up the world over. Earlier, there were just 3 drugs, Avastin, Macugen, and Lucentis, out of which Macugen is no longer available. They have stopped production of this because they found it wasn't as effective as Avastin and Lucentis. So Macugen is no longer available. Thank you.
Thank you so much, sir, for explaining and clearing doubts of all the participant doctors, sir. I hope that this topic is clear to all the participants. That's why we don't have any more questions, sir. And you have explained really well this topic, sir. That is the one reason also. Sir, I can see there is one feedback from Dr. Istiaq. He has written very well presented, and thank you so much for this session. Great presentation, sir. I hope that Dr. Istiaq really liked this session. And thank you so much once again, sir. Hope to see you again. As there is no more questions, sir, shall we conclude this session with
Yes,
all your
please.
permission?
Thank you. Thank you.
Okay, sir. Thank you so
Good
much, sir.
night.
Bye, sir. Take care, sir, and
Thank
hope
you.
to see you again with different topic in coming times.
Sure.
Thank you.